and she went like into the camera. It was actually hilarious. Okay, so you can do that, but I would just
I would consider that rapid
All right, Dan Friday. Good morning.
Hey, good morning, Garrett. How you doing?
I'm doing pretty good. How are you doing?
Great.
Sweet.
Yeah,
Thanks for coming
excited.
on.
Yeah, no problem. I'm excited.
Dude, I'm very excited. I have some questions to ask you, but let's start with who you are.
Sure. Yeah. Well, Dan Friday. I am the CEO of Redemption Psychiatry, and I've been doing that for over 7 years now. I have a history in healthcare. I actually was a CNA when I was 18, certified nurse's assistant. My first job was working overnight in a nursing home for $8.50 an hour, changing adult diapers. So
Nice.
Humble beginnings. Worked at ASH at the Arizona State Hospital on the medical unit with criminal and civil mental health, like seriously mentally ill people, and found out I actually really liked it. Moved to Tucson when my brother was in medical school, and he was nice enough to let me come live with him while he was a student, and worked at a behavioral health hospital in Tucson and some group homes, and then ended up going into private corrections because the pay was better, and did that for 8.5 years. Had a good experience there. Moved up into facility management, and that's where I ended up coming over to Redemption when my brother needed some help in 2015. So we've always been there for each other. We come from actually a pretty good sized family. We have 7 siblings all together, 3 brothers, 3 sisters for me. And Dr. Fred is my older brother by 2 years. So it's, that's me kind of in a nutshell. I mean, I have some interesting hobbies. I like to solve Rubik's cubes. I like to do this, the Society for Creative Anachronism, which is a medieval recreation society, and go out and hit people with wooden weapons. It's pretty fun. So
Nice.
Was a big D&D nerd when I was in high school. And yeah.
So I actually want to get back to the Rubik's Cubes later.
Okay.
Because I have a question about that. But let's start with sort of like the basic history of Redemption. What caused you to come on, and how did we get to where we are now?
Yeah. Well, I mean, part of the history is Dr. Friday's story to tell, but he went to...
It's okay. I interviewed him last week.
Okay, good. Yeah. So, right out of his fellowship, he completed his residency, completed his fellowship. He wanted to start his private practice, and his intention was just to have a small private practice in Gilbert with a couple other colleagues, and, serve children and adolescents and serve the community. What ended up happening was the demand for mental health services in that area was really high, and it was very underserved. And so he ended up expanding very quickly from 2013 to 2015. They went from 1 office to 5 offices, 4 working on a 5th. And he needed help with management. And so he asked me if I'd come help. And my initial response was, no way. I don't know anything about running an outpatient psychiatry practice. And what we found was, no one really knows. I mean, it's not something where the business model is perfected, and we can talk about that later about kind of how we developed our path. But when I came on, things were a bit dysfunctional. And so I don't know that I helped immediately, but 7 years later, we're doing pretty well.
So that was sort of what Dr. Friday talked about, is there's no template.
No,
not at all.
Not at all.
Especially for exactly what we do with TMS ketamine.
Yeah. I would say if there is a template now, it's because we started making it. Yeah. And I can point to a couple of examples where people did leave us and kind of try to follow the template. Yeah.
Right. Which is, it's good because it means if it's repeatable, it really works.
That's right. That's right. And the more people we can help, the better. And we don't look at that as competition.
Right.
So,
yeah. That's cool, because that's word for word what Dr. Friday said. So you're on the same page.
Yeah.
So we do outpatient psychiatry. What does that entail? Because if you asked me when I jumped out of my bachelor's, which was in psychology, what outpatient psychiatry was, I would not have described what we do here.
Okay.
So, and I think that's especially ketamine, TMS, QB. So what is it that we do here?
Well, my understanding as a layperson, I'm not a doctor, psychiatry is really treating disorders of the mind. And I think that's a distinction. People think about disorders of the brain. Well, that would be the field of neurology. And neurologists can use concrete tools, angiograms, neuroimaging. They do concrete fixes. They do, surgery, and they can, we don't have that type of, finality or something that's concrete in psychiatry. It's very much, we're treating disorders of mood and behavior. So to do, outpatient psychiatry, first, I'll just contrast it a little bit with inpatient psychiatry, right? So inpatient, a lot of us are familiar with some inpatient facilities which are treating primarily either substance use disorders, eating disorders, or
SMI.
SMI, acute psychosis, suicidality. Those are the things that, for people's own safety, we have to put them inpatient. And because we have to monitor them medically, things like that. So outpatient, we're not able to treat those things that require any type of hospitalization. We can't treat eating disorders that require hospitalization, or substance use disorders, because we don't do detox, and we can't monitor people if they're anorexic and they're not healthy or well physically. Then those are not things that we can treat. So outpatient psychiatry consists primarily of doing evaluation and management visits. Patient comes in, and at their intake, we get a really thorough history, do a thorough exam, and hopefully through that we get a good diagnosis. And that's the goal for every provider in outpatient psychiatry, is to get an accurate diagnosis, and then using their training and experience, prescribe a treatment that hopefully will get a desired benefit to that diagnosis. So we work in a world of, we're trying to improve outcomes. We're trying to get people to have a better quality of life. We don't talk in terms of cure, because that's not something that really we think. It's all about progress, and it's about a journey, and it's about making changes. It's ongoing. And so for us in Redemption, a lot of outpatient psychiatry, historically, they use what we call conservative management or conventional treatments. And those would be medications and talk therapy. And those work great. And those work really well for the vast majority of cases. And so that's a lot of what we do. Even our prescribers are doing talk therapy in the sessions. Now, we don't do individual counseling. We refer out for that, and we can talk about why. But the tools that we have with TMS and ketamine are to supplement the conventional treatments when patients are not responding well to those. And I can stop there. We can go into TMS, ketamine.
Well, I think we can.
Or just advanced treatments in general.
Yeah. So the advanced treatments are very interesting from working with providers here. Melinda, Emery, Casey. One of the things that I've learned about outpatient is there's two primary types of patients. There's patients with sort of chronic problems that are not so severe that they end up inpatient. And some of them have gone a long time living substandard lives, or lives with quality, or having quality of life that is below what they could have, because they weren't severe enough for inpatient. And so they come here. The other I see is people who, if untreated, would very likely be inpatient, right? Who are headed down that road. And that's where I see TMS and ketamine come in very often, is it actually heads that off. So yeah, with that, I think we go into kind of what they are and how they work. Sure.
Well, one of the things, first I would say what we see most of in outpatient psychiatry, if we actually keep statistics on our diagnoses, and the number one thing we diagnose actually is anxiety. And the main reason for that is most people have that comorbid with other disorders. So it's not to say that we treat mostly anxiety, but we treat a lot of anxiety comorbid with depression, or even, ADHD or something like that. So anxiety, depressive disorders, those are our top. And then ADHD is probably right up there. There's a lot of attention problems, but OCD, PTSD, those are the things that we see a lot of, bipolar disorder. And so TMS and ketamine is not those are two advanced treatments that we use, but they're not going to work for everything. So I think what our providers are really specializing in is identifying when someone is going through conventional treatments for a disorder like, let's say, depression, and they're not responding well to treatment. So they're really in a bad, I mean, they're in a tough spot sometimes when they're looking at, talking to a patient. They have a lot of decisions to make. Should we add more therapy? Should we consider sending them to an intensive outpatient program for therapy? Should we increase the dose of medication? Should we change medications? Should we, are they a candidate for some other treatment? And let's say it's ECT, right? So if it was ECT, electroconvulsive therapy, which we do refer for quite, a fair amount, then you got to go through the risks and benefits with the patient. What are their likely outcomes? What's the prognosis? How likely it is that treatment will help their condition? What are the costs? What are the risks? What are the benefits? All of those things. And so the providers, they only have 20 minutes here for a med follow-up. And so if they're trying to get through all those risks and benefits in that 20 minutes, sometimes they don't have time to go over all the options.
Right.
So what we've done in-house is, if it's something, and I assume, like when we send people for ECT, they go for a consult, right? And I assume during that consult, that's when those providers there go over all the risks and benefits. So in-house, we've developed the treatments that we find most beneficial. So TMS, we started in 2015. So transcranial magnetic stimulation. It was right before I started. We had purchased 2 chairs from the top manufacturer in the United States. And we started trying to figure out how to use this technology. There was good evidence for it. The numbers were basically 40% remission for depression patients and 80% response. So we looked at those numbers and said, that's great. So we started doing our own treatments and found it's actually quite challenging, not necessarily to do the treatment, although there are some technical challenges with getting people trained and getting patients comfortable with the idea, because it's something totally new and novel to them. But mainly it was making it financially viable through insurances, because not every insurance was covering it at that time. It was FDA approved in 2008, but insurance companies don't, just because something's FDA approved doesn't mean they're going to cover it. And then even when they do, they put an inordinate number of restrictions.
Caveats.
Because they can pick, for our medical policy, for this medical necessity of this device, the FDA approval might say treatment-resistant depression in adults. And the insurance company might say, well, that to us means adult is actually 21 and up. Well, but everyone else would say it's 18. Yeah, but for us, it's 21 and up. And treatment resistant means tried and failed 4 medications. And some other people might say 1 or 2. Nope, it's 4. So they can set those rules. And they can also set rules to say you have to use an approved rating scale to determine severity. Which is
PHQ-9 GADS.
Something like a PHQ-9 or a MADRS or a HAM-D or some other rating scale. That's not in the DSM-5, right? So in the DSM-5, the statistical manual for providers to diagnose mental health disorders, you're going based on symptomology as determined by a trained professional, right? Now, the rating scales are good tools that professionals have developed. I mean, these are developed by psychiatrists, and they're tested and they're vetted and they do work well. But it's kind of arbitrary for the insurance companies to get to say, you have to use X rating scale or we won't,
Right.
And some of them do, some of them are more lenient. But yeah, that's, so what we do with TMS is we've developed our program around helping our providers to know when that treatment is appropriate, right? To identify patients that would benefit from it. And then having an internal referral process for them, because 20 minutes isn't enough time for them to go over all the risks and benefits. So we have TMS coordinators that will reach out to the patient once the provider refers them. They'll go over all the risks and benefits. They'll show them what the cost would be for their insurance. And then they'll get them scheduled for that initial visit. And that initial visit is with the TMS provider, so a physician who's doing their motor threshold, and also the TMS tech will be there. And then they'll get that treatment that first session and kind of go from there. But they'll schedule them for a course of treatment, which is 30 to 36 sessions of TMS.
Right. So Rubik's Cube.
Let's just switch gears here.
There's a reason, actually. I promise it all folds in. Can I ask about the Rubik's Cube and TMS techs?
Well, first I'll tell you about how Rubik's Cubes came into my life.
Right.
So
Let's start there.
I'm 42. When I was 38, my kids brought me a Rubik's Cube and asked if I could solve it. And I said, you know what? I've never been able to get more than one side. Like I can't help you,
Right.
And then I remembered that the internet exists, right? So when I was a kid, it did not.
Right.
And I said, I wonder, let me just Google it and let me go on YouTube and watch some videos. And that first day, I solved Rubik's Cube. It took me, 12 hours or whatever, walking through it step by step with guides. And then the next day it took me 10 hours and then 5. And then I just kept working down until I was like, okay, I've got the algorithms memorized for a basic beginner's level. And I just started working through it really quick. And now I can do it under a minute. So. And then, but what I realized was the method of solving Rubik's Cube is a systematic approach to a problem. Now, the thing about a Rubik's Cube is all the variables, right? And it's a fixed, closed system, but you're using an algorithm to solve it. And so I developed a really kind of a spatial reasoning test, a test for people to be able to say, can you follow written instructions and directions? And I incorporated this into an interview process that I use now for our TMS techs. So I give them a solved Rubik's Cube and I give them some instructions that if they go through a simple algorithm, a certain number of times, it will go through that solved process and it'll come back to a solved cube. Yeah. Now, if somebody can do that, they can use their hands to manipulate an object in 2-dimensional space, right? And they can follow a set of written instructions with diagrams, then I feel confident that they can learn to be a TMS tech, because it involves using both your hands at the same time, using some spatial reasoning
and translating information.
And yes, our training process would include being able to use diagrams to learn and position things, and that's how we learn. So it just happened to be one of those tests, and I think it works really well. Most people look at me like I've got 2 heads when I hand them a Rubik's Cube, and they're like, but if they can do it, they walk through it. It's also, I think, part of that process during the interview is overcoming the anxiety, and just being willing to go through the process and realizing I have confidence in myself. Yeah.
Right.
Yeah. I give them 3 tries.
That's fair. Yeah. So, to kind of make that a broader question, what are some of the unique challenges that you face with outpatient psychiatry? We established there's not really a template.
Yeah.
And what are sort of modalities wouldn't be the right word in this context. What are sort of tactics that you've learned over time to help you solve them? It's
a great question. I think the initial challenge that we face is determining what population we want to serve. Some people narrow their focus and they can serve a population and it works really well for them. And a good example of this is you have, and I'm not disparaging anybody by populations they choose to serve, but there are some psychiatrists that operate in affluent areas and they only take cash. They don't take commercial insurance, and they get a certain type of clientele, right? A lot of it is, people who obviously can afford to pay cash for their services, and some of them are just the worried well, and some of them kind of want a concierge medical service, and that in itself is not an easy gig by any means, but that is one avenue people choose to take. Another one would be to work through a government agency or a facility doing psychiatry, because it's kind of a closed system. Some of these providers get capitated rates. Sometimes they're only seeing 6 or 8 patients a day, but they're serving a certain clientele, and that clientele needs services. When we came on, what we noticed was there was kind of a gap between those two, and really it was difficult for people with commercial insurance to find a quality mental health professional that was near them, that understood not just a small range of disorders, but was able to help them. And also the age range is another big factor. So even if you could find somebody to treat you as an adult, but you may not be able to find someone to treat your 6-year-old. Right. So, our age range now is, we say 6 to 64, mainly because most of our providers, a lot of the nurse practitioners are actually not able to see younger than 6, but also younger than 6 in mental health and behavioral health disorders. It gets tricky. And a lot of times it's actually more appropriate for them to see like a developmental pediatrician, but we can see younger than that. And some of our providers do. It just kind of depends. But 6 is the general guideline for as young as we see. And 64 is the general guideline for as old, because beyond that, you actually get into a realm of subspecialty of geriatric psychiatry, and we don't have any geriatric psychiatrists. You also get into issues of memory care and other disorders that we don't treat. Right. And also a lot of those patients may have Medicare, which we don't take. And so we tend to say 6 to 64. I can tell you, we do have patients that are well beyond 64 years old. Our providers are happy to treat them. We figure out payment arrangements. We have to do an advanced beneficiary notice to Medicare, but we are able to see those patients as long as they don't have other disorders that we really can't treat that would preclude us from treating them.
Right.
So those are some of the challenges that any outpatient psychiatrist would face. The other challenges would be, one of the conventional tools is using therapy, and we absolutely love the therapists that we work with. We think therapy is essential. It's our number one referral is for therapy. We used to have therapists that worked in-house with us, and we ended up no longer having in-house therapists doing just talk therapy. Our prescribers do some therapy during the visits, but the reason we had to kind of make the shift was actually related to insurance. And a lot of it had to do with the fact that insurance pays very little for therapists. It's really shameful, actually, what they pay them for what they do. And so a lot of therapists would choose not to contract with insurance companies.
Just do it all cash.
Do it all cash, or only contract with one or two that were paying good rates. So when we were all under one roof, the psychiatrists, they all took all the major insurances, and we still do. We take Blue Cross Blue Shield, United, Aetna, Cigna, TRICARE, TriWest VA, Magellan, the big ones. And you would quite frequently have these just kind of logistical problems where a patient would come into one office, see their prescriber, pay a copay, then see their therapist.
Go cash.
But we didn't always get that right. And so the patients sometimes didn't understand that they had to pay cash to see their therapist. And so there were some logistical problems with that. And the people who were suffering actually were often the therapists that were getting underpaid. We were under collecting. And so some of those logistical reasons were just almost insurmountable.
Right. Therapists are not psychiatrists.
They're not. They're critical though. And so we, around 2018, said, you know what, we're going to refocus the whole practice, and we're going to specialize in psychiatry and do that really well, which means doing outpatient psychiatry with medication management and advanced procedures, and then referring out for those services that we don't do well. And we recognize that we don't do everything well. And so that's kind of what the template became. So today we have 4 locations. We have 2 in Gilbert, although this one we call Mesa because it's at Val Vista and Baseline, and it's right across the street. But to distinguish it for ourselves, we have Mesa, Gilbert, Chandler on Dobson and Pecos, and then 32nd Street and Cactus is our Phoenix office. And each one of those locations, we have about half the space dedicated to psychiatrists and nurse practitioners doing evaluation management, and about half the space we dedicate to procedures. And we do TMS and ketamine in all those locations. And when ketamine came on the scene, and I know I'm kind of going on different veins here. No,
you're good. Keep going.
We started developing out TMS from 15, 16, 17. We actually changed to a different device in 17. And now we have 11 of those devices. 10 of them are in use, and we have one as a spare because that's kind of what if one goes down, we don't want to stay down for long. Right. And I just think some of those decisions that we make as a practice are what helps us to be successful. Whereas if we were not a privately owned sole proprietor, Dr. Friday's business, we couldn't make those decisions. People would say, well, you don't need to have an extra device just in case one goes down, but we do, right? Or patients would go without treatment. So we have those, we have all of our locations set up very similarly, and we do TMS, and we do it really well. And one of the things that we developed with TMS is if we can get paid through the insurance for major depression, that's not the only thing we can treat. And quite often patients have comorbid disorders. So if we have them in the chair and we're treating them for depression, that treatment takes about 18 and a half minutes. The appointment's for 30. So we looked at it, and the providers were like, well, there's this other treatment we could do for anxiety, but the insurance won't cover it. And we said, you know what? Well, we don't need, we'll just do it.
They're in the chair.
They're in the chair. We won't charge the patient for it. We'll just do that treatment. And then they said, well, there's this other one for PTSD or this one for OCD. And so any patient that comes through that gets treatment for depression and their insurance is covering it, if we have them in the chair, we will do any other adjunct treatment that we can that's appropriate, that the doctor wants us to do, whether it's for OCD, anxiety, PTSD, migraines, insomnia, If there's evidence behind it and we have a treatment for it, we'll do that treatment at no charge. And I think that makes us very different than what other people, because other businesses might look at it and go, you're missing out on this opportunity.
Right.
You have this great opportunity to upcharge and upsell, but it's not the right thing to do. So when ketamine came on the scene, we actually were investigating it because of the report and the study that was done, that we saw it was 70% effective at reducing suicidal ideation in one treatment. And that's how we started using it, actually, because in outpatient psychiatry, the worst day that psychiatrist has is the day that a patient comes in who is acutely suicidal. They cannot get them to contract for safety. They are in fear for their lives, for their patient's life. And their only recourse was to contact crisis, get them inpatient. When that happens, the patient oftentimes does not want to go, and sometimes even needs to be petitioned to go. But even then, sometimes they do end up going through, pressure. Parents or spouses or the provider. But they end up missing. They're in the inpatient for 3 to 7 days is kind of normal. They miss school, they miss work. Inpatient provider might change their medication, they might change their diagnosis. They may have some other unwanted outcome while they're in the inpatient, in interactions with other patients or things like that. And then they have a huge bill when they get out of the hospital. This is, even if their insurance covers it, they still have this enormous cost. So that is and they've lost trust of their provider. And that's really the worst thing is, they came to us for help and we couldn't help them. We had to send them somewhere else to help them. So when we started looking at ketamine as a means to avoid a hospitalization, we said, well, if you're in that situation and you tell the patient, this is what we can do, these are all the things, if we have to get you inpatient because you're suicidal, this is what's going to happen. And then we offer them this alternative and say, but we could try a ketamine infusion. And the studies said it was 70% effective at reducing suicidal ideation. Do you want to try that? What we felt would be wrong, morally wrong, is to say, and also it's a $500 infusion. So if you can pay for, and honestly, I think some people would still justify that, and it would be justifiable to say, but the hospital says it's going to cost you $10,000 or whatever, so it's worth it. We said, no, we don't want that to be a barrier. And so we started doing them pro bono, even though it cost us quite a bit. I mean, we have to pay for the nurse, pay for we didn't charge patients for it because, I would say that's the most successful program we have. I don't know of any times that we've had that patient needing an emergent ketamine infusion to avoid a hospitalization, that we did the infusion and the patient still ended up in the hospital. I don't know that that's ever happened. So I hesitate to say we've been 100% successful, but
they're good numbers.
It's approaching that.
Yeah. Yeah. That's awesome. I think it speaks to kind of the gold hammer problem. What's worth more, a hammer or a gold hammer? It's a gold hammer, right? It's made of gold.
I guess, except, the worth of a hammer would be in its utility.
Right.
Gold's pretty soft.
So what's the point of who would buy a gold hammer? No one. It doesn't make any sense. Right. And I think that's the problem. I promise this comes back. That's the problem with super advanced specialized treatments that cost so much money that it's not possible anymore. Right. Is you're selling a gold hammer. Yeah. It's worth it technically. Right. But who would possibly do it?
Who could do it? Yeah.
Right. And I think that's the beauty of sort of the first ketamine being pro bono and the add-on procedures to TMS is that we take the gold off, we sell you an actual hammer, and it actually makes sense.
Yeah. I mean, in medicine, there are never any guarantees. Right. All of our treatments, anything we do, any medication we prescribe is going to come with the caveat of, this may not work for you, and there's a failure rate along with it. Ketamine, the way that we do it is one of the very few procedures in medicine that there's almost never a try before you buy type of,
Right.
And so doing that pro bono treatment actually gives a patient an opportunity to know, is this a treatment that might work for me before, so I can make a rational and informed decision about my care and know if it's worth paying the cost of, which we're even to pay for ketamine infusions with us, we're still, I think, one of the lowest cost in the country, to be honest with you. I mean, but they can make an informed decision on it, knowing whether this treatment will work for me, as opposed to everything else in medicine, which is you got to pay up front and it may not work for you. And if it doesn't work for you, you don't get your money back, And so, I mean, of course, there's no money back guarantee with us either, but you get to try the first one and know if it's going to work for you. Right. So.
Yeah. That's also the cool thing about payment plans. Because the irony of a problem is if you're dealing with depression, anxiety, it probably is impacting your work. But you can't get out of it if you can't work enough to pay for it.
Catch-22.
Exactly.
Yeah. Or you can't work, so you don't have insurance or
right. What makes Redemption Psychiatry different?
So I think one of the things, and I touched on it a little bit, that makes us different is the fact that we are a physician-owned practice. We don't have, investors. We don't have, so we don't have shareholders. Right. We're not beholden.
There's no mystery man in a suit making decisions for you.
Right. So the owner is a physician, and the decisions that he makes, generally speaking, are out of what's best for the patients, medically speaking. And I tend to be the voice of reason to say, we can't give all the care away for free, Dr. Friday. We have to charge for some of these things. But we make really tough decisions to say, how thin of a margin can we operate on and be okay with that? And we don't have anybody, no board of directors coming back to us and saying, this is too narrow of a margin. You've got to increase the profits because it's for them, for the board. We don't have that. So I think that's one of the reasons that we're different. I think the other thing that makes us different is that we are innovative. We look at any new or existing treatment. We evaluate it based on evidence, how effective is it? And if it's effective and it's something that our patients could benefit from, we will look into it. We'll try it. And we're not afraid to try something and have it fail. So we actually, there's a device, I think the device people might be familiar with is called a Fisher-Wallace device, but it's a TDCS, so transcranial direct current stimulation. It's like a TENS unit for your head, it passes so you put a cathode and an anode, and pass a mild electric current off a 9-volt battery through the patient's brain. It's very superficial. It does have a success rate though for depression and other things, same things TMS would treat. The challenges with that were placement. It was very tricky. It was a take-home, use-at-home device, so adherence is tricky. But the device was very inexpensive, relatively, $300 or so. And patients can actually pick up one of these devices and try it if they want. We recommend it for patients to take this home and say, after TMS, if they wanted to get one and boost their results. And we were doing that quite a bit. We actually even developed a cap that would help with placement. It was something that never really caught on. There were other treatments that were just the way that we were using them were more effective, and patients really didn't dig the TDCS devices. So I have a few of them in my office if anybody wants to buy them, because we don't use them anymore. But those
sitting there,
but being willing to try something and have it fail, and being okay absorbing that result, I think is a thing that sets us apart. There was a program we started that was really interesting called Play Attention. And it was a device.
I've heard of this. Yeah.
So it was a device that the technology was using was actually reading brain waves, and it was like a video game. You'd put on an armband and you'd focus. And if you could focus, you'd make the characters move, or it was like a submarine, and it would like go up or down. And we had a group that we would do. Patients would come in, and this was cash pay. I mean, we were, couldn't get insurance to cover it. They would come in, and we'd have these kids go, and we'd have somebody who would moderate and facilitate that. And, it worked for a time, but it just was really kind of fraught with problems. And so we couldn't, continue that. But there have been other things that we've tried that have been wildly successful. And so I think that's, if as a practice, you don't have some risk that you're willing to take. And not to disparage psychiatrists, my brother's one, and I love psychiatrists. They tend to be risk averse. And part of that has to do specifically with procedures. Whereas, like, just as an example to compare, psychiatrists don't get into a field of medicine where you are doing surgery. They don't get into a field of medicine where they're using anesthesia and cutting bodies open. And in fact, a psychiatrist never actually has to touch their patient to treat their patient, right? So it's not surprising that you have some anesthesiologists who are very comfortable using a medication like ketamine that have started treating patients with ketamine because they're so comfortable with it. They've used it. It shows great efficacy for pain, for PTSD, for depression, for suicidal thinking, really good results. And I don't see any issue with those providers that are comfortable with it, using it. I wish more psychiatrists would use ketamine for mental health disorders, but I think the reason that you don't see a lot of it is because they are not comfortable with it. They are somewhat risk adverse. And I don't know that for sure. I'm just the ones I've talked to. I mean, I think that
Right.
that could be the case.
It's common disposition.
And so,
I mean,
and I think it's changing. But that is one of the things that I think set us apart initially was
right.
we were willing to take risks.
Right. Well, how entrepreneurial can you be to sit through all the med school?
What do you mean?
Like, I don't know. I think that if your disposition, your personality is very take risks, go get it, try things, it fails, try something else, keep going, like super fast. Could you sit through all of med school?
Oh, those people don't tend to
Like,
go.
do you think it would
It's
weed them
interesting.
out?
I don't know. I mean,
I don't know.
If anything, I would say, I mean, so Dr. Friday is one of the most remarkable people that I know. And he's very unique, I think, in that being a doctor and a business person and an entrepreneur. It's you're right. I don't think it's something you see every day. And so I think that's another, like I said, being physician owned and having that physician leadership as well as the
Both sides of the aisle in one person.
Yeah, I definitely think that that's one of the things that sets us apart. So.
Cool. Well, Dan Friday, thank you very much.
Yeah, awesome. No, this is great.
Yeah.
Great. You don't want to see me solve the Rubik's Cube? Huh?
Do you want to solve Rubik's Cube?
I'll do it.
All right, let's solve the Rubik's Cube. Give me a second. Go. All right.
Good job, Katie. You scrambled it really well.
Oops. Impressive.
All right.
So 40 seconds.
Yeah, probably
great.
closer to a minute, but yeah. Pretty good.
6:48 to 7:32.
Oh, that's good.
Yeah,
Not bad.
just like that.